Hello, everybody, and welcome back to the second episode of the Rehab Chiro podcast. Today, I am here with the lovely and powerful Adam Meakins. Adam, how are you doing today?
I'm very well, Elliot. Thanks for the invite. Looking forward to the chat. Long time coming.
Yes, yes. So, we got a lot of good questions in from. I just briefly posted a story asking if anyone had any questions for you in particular, and I think that we should start there because that's a good segue into the questions that I had for you as well,
Sure.
which is great. So let me pull those up real quick.
Any beard related questions?
You know what? It's funny you say that. We got a couple of meme questions, and I think that might be a good topic to start on. One of the first ones was Vegemite or Marmite?
Oh, Marmite, definitely. Vegemite's an Australian thing. As a, as a proud Englishman, I'm going to say Marmite, definitely.
Okay. Um, this one will kind of flow into the first question that I originally sent you that I wanted to go and talk to you a little bit more deeply about. Why did you choose physio in the first place?
Yeah, a bit of an accident, if I'm being honest. I had a bit of a roundabout path journey into physiotherapy. So I left school at quite a young age, came from a military family and joined the military first. So I had a couple of years serving in the army, in the British Army, and thoroughly enjoyed it and was planning to stay on there pretty much for most of my adult career, or so I thought. But as happens, life changes. And so after a few years of service, I came out of the military and was on civilian street, not really knowing what to do with myself. So I thought I'd go and retrain into something that I was quite keen on and had an interest in, and that was health and fitness. So I went and did my first degree in sports science, which basically, after 3 years of learning a lot of stuff around exercise physiology and things along those lines, gave me a glorified personal training certificate, I think is the way I would describe it. So I worked for a couple of years as a personal trainer, and I'd say a rather overqualified personal trainer, but there we go. And started to get interested again more in the clients that I was having with injuries and pains, and not really sure about what's going on, whether it was safe for them to carry on training with me or not. And thought I would try and expand my knowledge into the world of pain and injuries, and thought the best career and best sort of job for that is become a physiotherapist. So I applied to do a second degree, which surprisingly they accepted me. And yeah, the rest is history, as they say.
Very cool. Okay, that's awesome. I had a after college, I went to chiropractic school, kind of on accident too. I was pre-med at the time and didn't realize that chiropractic was so steeped in mysticism because all the chiropractors that I crossed paths with were very, very evidence-based, just out of sheer luck. And then I got to chiropractic school and I was like, what is going on? And it was crazy. But I too was personal trainer for, let's see, by the time I entered chiropractic school, it would have been 6 years, 7 years. I became a personal trainer as soon as I could. So about 18 years old. And then I just kept training. And then that kind of led me into chiropractic as well. And that we'll get into that a little bit later. But that personal training experience kind of formed the bulk of my like exercise repertoire, especially because chiropractors don't necessarily get a whole lot of active care stuff. So when it comes to rehabbing injuries, a lot of what I learned is through trial and error from being a personal trainer and then shadowing different physical therapists and like outpatient clinics and whatnot and seeing their sort of protocols for different injuries and assessing and stuff like that. So that leads us into our first question. So how do you currently practice? What's your setting like, your demographic of patients, and do you practice in the private or public sector?
Both. So I work for the National Health Service in the UK, which is our public health service, which is struggling and going through some challenges at the moment due to governments and politics. But it's a free for healthcare service, free for all. So we all contribute with our taxes as British citizens to pay and fund for the NHS, and the government make sure that say that everybody gets free access to all the treatment and healthcare that they need. But it is, I think, say over these last few years, poorly managed. So it's going through some difficulties and changes. But I've always worked in the NHS for most of my career as a physiotherapist, and I'm still in there now, 22 years later. But I wouldn't class my role now really as a physiotherapist role. So I'm more of an orthopedic registrar or an orthopedic consultant role now. So I work in a orthopedic and trauma department and work in the upper limb team. So the orthopedics and traumas split into upper limb, lower limb, and spinal. And 2 days a week, I work in the orthopedic outpatient clinics with the consultants and the registrars, triaging, screening trauma patients who have come from A&E, and we need to check their pathway and see what does or doesn't need to be done with certain types of acute traumas and fractures. And then we have a look at the more less acute type of stuff later on in the day. So we get a lot of referrals from secondary and tertiary sources, GPs, physios, and other likes of healthcare professionals asking for our orthopedic specialist opinions on chronic shoulder, upper limb, elbow, neck type problems. So that's what I do pretty much, say 2 days a week. And then I work in the private sector as well for myself, offering online consultations now predominantly. So I don't actually have a clinic anymore privately. So I do some infrequent online consultations to people that reach out and want some advice, guidance, consultation around various different things. And funny enough, I find I get a lot of requests from America, I think. So I think about 75% of all people that I consult online 2 days a week, yeah, come from across the pond. And I was quite surprised at how much they were quite happy to pay a physiotherapist for an online consultation. And I think when I've heard some of the prices that their healthcare system charges and how much they've been paying for consultations, I can sort of understand why they're quite happy to pay my fees. But compared to what I would charge somebody in the UK, it's a completely different rate, but that's another story. But yeah, no, so it's a split role, say, between public and private. And I've had lots of different experiences over the years. So that's my current role, but I've worked in busy NHS physiotherapy clinics, seeing up to 40 to 50 patients a week. I've worked in professional sports as well, professional football, professional rugby, and yeah, just had a sort of broad experience of various different avenues and aspects of helping people with musculoskeletal problems.
Very nice. Okay. That leads us into there's another FAQ question that kind of ties in nicely to the point that you just made about the online physio space. How do you feel that that space is growing? And do you feel that there's like a future in that online physio space? It seems to be a little bit more prevalent now than, the brick and mortar physio sector. There are a lot more people offering those interventions.
Yeah, I think obviously with the pandemic, it shifted a lot of people's thought processes on how healthcare consultations could be done. So I think that's one of the good things that came out of that shit show is that a lot of people realize that, a lot of healthcare can be done online. I'm not going to say all of it. I'm not going to say it's perfect. There are limitations with online consultations, of course there are. But, people sometimes just want that ease of access. They want that sort of instant ability to be able to talk to someone, get some advice, get some guidance, or just to have the knowledge that what's going on isn't anything for them to be overly alarmed or concerned about, or they don't need to go and see somebody for some further tests, investigations, or they can carry on doing what they've been doing, or do they need to change or alter anything? And that's where I think these online consultations come into their own. It just gives people that ability to connect quickly and be able to ask these questions that are playing on their mind. But it isn't perfect. It is sometimes a limitation, a barrier with communication. I find sometimes you can't communicate quite as well, I think, online as you can do face to face with people. You don't get the same sort of nuances in interactions online as you do clinically. And of course, the assessment process can be quite challenging as well, getting people to change the angle of their cameras so you can see where things are going and what things look like. That can all be a bit awkward and difficult to arrange. So yeah, it is something that I think has utility, but it's not suitable for everybody. And again, the other issues, some people can't use the technology. I've had a few older patients that were just struggling. So the older generation still sometimes, it's the technical barrier rather than the actual, consultation barrier that's the problem to overcome.
Yeah, those are all good points. Yeah, for me, I do a lot of online consults as well, and it seems to, especially because of what I see, kind of like you said, other people are charging egregious rates for things like this just to get a little bit of an expert's time. And
Yeah.
I think that the funny thing now is with the advent of chat gpt and grok and all this stuff, I think that the online physio space is about to become even more interesting with these online consults because these ai engines can do seemingly a lot of what we would give our own patients. You ask chat gpt what you would do for a patient with chronic non-specific low back pain, generate an 8-week protocol, and it'll spit out something at you. It's missing that human element, but at the crux of it, the rehab protocol is not too bad.
Yeah, I think AI definitely has some, you know, parts of it that can definitely help a lot of people, but there is, as you say, that human element that's going to be missing. And I think, there's still that doubt about trustworthiness, accuracy as well, that still hangs over a lot of people's minds. And I think sometimes that can't be replaced without actually going to speak to somebody face to face. Yeah.
Yeah, 100%. Following up into a former point that you made and something that I said about personal training in particular, being that we were both personal trainers at one point in time, what helped you build up the bulk of your sort of exercise repertoire? Was it what you learned in school? Was it external curricular seminars? Was it trial and error by being a personal trainer? What was it?
A mixture of all of it, if I'm being honest, Elliot. Is a lot of it was, if I'm being honest, my own sort of personal experience of being trained by other people, and feeling all various different types of exercises on my own body, and understanding what that felt like and what things sort of responded better than others. So I think that's been probably a huge part of what's developed my preferred choices of exercises that I inflict on my others based on my own decades of experience of it. So, and I've done all sorts of stuff. I've been on various different seminars and courses and been taught various different ways of doing various different types of exercises, and some just don't feel as good as others. I remember the days where it was all about unstable surface training, about how we had to go and learn how to do things on Bosu balls and Swiss balls and things like that. And I just never got on with it. I just never felt it that when I was doing it, it was doing anything with real significance. It was a bit of a novelty. There's a bit of a gimmick behind it. It was a little bit fun for 30 seconds. But if I was thinking I needed to do this to generate strength and hypertrophy or even flexibility and mobility, I'd be like, nah, that stuff ain't gonna cut it. So I just know, I think from that sort of own personal experience, really, over decades of playing around with various different types of exercises, where I've got most of my repertoire from.
Yeah, it's funny you say that. That's probably the most common question I get, and it's one of the common questions that we got in FAQ. It's how does Adam do rehab, or how do you do rehab? And one of the things that I tell students in particular about to make the transition to physio or chiropractic school is if you could go back in time, go be a personal trainer for several years before you actually go and step foot into the school, because then at least you'll have a decent base and a decent ability to troubleshoot what happens in real time with a client if an exercise doesn't feel right, how to modify things, how to attenuate load, and do all those things that are invaluable when you're a physical therapist or a chiropractor.
Totally agree. As there's two things I recommend to all aspiring therapists who want to work in the musculoskeletal space, and that is to, as you say, is either go and work as a personal trainer or just train regularly yourself and experience a lot of variety of different types of exercises and training, but also go and work in some customer service job or industry as well. So go and wait tables, go and sit behind a customer service desk or something along those lines, because the skills that you get in interaction and communication there, I think, are also invaluable for a good therapist in musculoskeletal therapy. So it isn't just about the exercise aspect of it, it's also about the coaching side of it, the communication side of it as well.
Right, 100%. I agree. Okay. Follow-up question that's a little bit more clinical and a little bit more straightforward and on the nose. Do you currently use any form of manual therapy? And if not, why?
Well, it depends on what you define as manual therapy. It's, I shake a lot of people's hands. I give encouraging back slaps, a couple of fist bumps every now and again. So, does that come under the term of manual therapy? Well, obviously not. But simple answer is no. I've moved away from doing any formalized forms of massage, joint mobilizations, high velocity manipulations. I don't do any acupuncture or dry needling anymore that I've been taught to do. And I very rarely use anything like tapes and stuff like that as well. So I'm very, very much now. I'm not anti these things. I've just moved away from them. And I think part of that is because my roles have changed in healthcare now. So I'm in a role that's more about assessment and triaging rather than treating. So if anybody needs any physiotherapy treatment, I refer them into the physio team, and the physio team do all that business. I don't now. I just review and oversee progress and how things are going. And obviously, with online consultations, there's no physical way I can do manual therapy, not unless you believe in all that aura and energy claptrap that I've seen some people doing online. But no. So yeah, I've moved away from it now. But I did have a big kickback 10, 15 years ago against manual therapy. And looking back now and a little bit calmer, older, maturer phases, I've realized that perhaps I was a bit harsh on manual therapy, but I think I had good reasons to be. I felt very aggrieved and pissed off at the fact that I'd been lied to, hoodwinked, led to believe that manual therapy was this skilled, specific, specialized thing that I'd spent years of my life trying to perfect and get better at, and also spent probably thousands of pounds on getting certifications into it as well. And that's sort of when I started to read the research and understand, it's not as simple as everybody's been able to make out. Yeah, it pissed me off, and I had a bit of a kickback against it, and still do a little bit. I still think it's still surrounded by a lot of nonsense, over complexity, over promotion. And there's also a lot of arrogance and ego around it with those that teach it as well, which hugely annoys me. This belief that, and I don't want any therapist to go through what I went through, which is that sort of feeling of disillusionment and worthlessness that I think a lot do when they go on these manual therapy courses, because they're led to believe that you should be able to feel a sacroiliac joint move zero point 0.5 degrees underneath somebody's 6 centimeters of adipose tissue. And I'm just like, there's no physical way you can do that. Oh no, you just need to practice. You need to practice. You need to get your Jedi palpation skills up. And so I just find a lot of therapists sometimes they get a little bit disillusioned that they're able to feel these things that they're told they should be able to feel. And it does make them feel, I think, worthless, like I did. I very much was thinking that I'm a bad physio for many years because I couldn't do these things that I was told to do. So that's why I've sort of moved away from it, had a bit of a kickback against it. And I also find, if I'm being honest, it's not necessary or essential in a lot of people that I see. I'm not going to say it doesn't help some people some of the times, of course it can, but is it really needed or necessary? No, absolutely not.
Yeah, I had a similar academic experience as you did. I remember going into my first ever technique course for chiropractic, and the instructor saying something like, by the end of this course, you should be able to feel human hair through pieces of paper. And I remember thinking, what is this guy talking about? And slowly but surely over the course of the year, different people and different students would say, "Oh my God, well, I can do it now. I can do it now." And I'm sitting there thinking, are my hands broken? Are my mechanoreceptors so crude that I can't feel this hair? And then I just kind of similar to you, I became upset almost at the speed, the quickness, and the how obsequious people would be when it came to manual therapy instructors, and that caused me to become a little bit cynical over time, which actually started my page. My page was just a way for me to vent about my chiropractic school experience and how I thought everyone around me was a little bit crazy, and how I felt that I was going crazy because I wasn't like them. Um, so that was my experience. But I thought it was interesting how you pointed out that your role influences some of the interventions that you choose to utilize right now. I have a lot of mentors who are chiropractors who work in hospital based settings, and similar to you, they work on the spinal orthopedic side of things. And so their primary goal is just to basically be a diagnostician and then to oversee the course of care that the physio is employing on their patients. And so that makes a lot of sense when you're talking about the fact that you don't use manual therapy anymore, utilize intervention, because maybe you leave it up to the physiotherapist as to whether or not they do that for the patients, which these people are educated, fully sentient, know what they do, know what they're doing, are giving their patients an informed consent. And that's a lot of what I also believe should be. That's a lot of what I think the manual therapy conversation should head towards or morph into. It's the almost like the informed consent discussion, and taking away the mysticism from manual therapy. Not that these choices are bad, but that you don't necessarily have to use them. And if your patient is informed and they consent to using them, well, then go on, give it a whirl.
Yeah, totally agree. And I do think the environment and the populations that we work with dictate a lot of how we work massively. And so if you're in a clinic with other clinicians and it's a very manual therapy based clinic, you're probably going to feel the pressures to do more manual therapy on your patients just because of the environment that you're working in. Whereas if you're in more of a rehab clinic setting, then you're probably going to use less manual therapy. And again, your population will also dictate that to you. When I worked in professional sport, these guys always wanted manual therapy treatments. You know, I don't think the rehab really came into it at all much a lot of the time. That was the stuff they were, doing pretty much on their own without much of us having to G them up, oversee them, or anything along those lines. They were very much just wanting the physiotherapists to do the massage after the games and the training. They wanted that manual therapy. And I think, in those sort of populations, there's definitely probably some more benefits for it. They're the ones that have probably going to get the relaxation and the parasympathetic effects so much more after they've had, a stressful period of exercise and running around. So those populations probably do benefit more from these manual therapy techniques. So yeah, populations and environments very much do dictate practices of healthcare professionals massively.
Yeah, that's a good point. And my follow-up question to that was actually to give you a hypothetical of a patient who I think I just want to lay out a hypothetical for you, because I think a lot of people, when they hear your take on manual therapy and my take on manual therapy, I've had a lot of chiropractic students, especially even going through school, saying things like, if you don't use spinal manipulation, then what are you going to do? What other interventions are there? And it boggles my mind. I'm like, there's a bunch of other things that you can do specifically for pain. Everything basically works for pain. I was like, there's so many other interventions that you can choose from. That's just one thing that you can do. So I want to lay out a patient case for you to see whether or not you think manual therapy would potentially be appropriate.
Okay.
And give me just sort of your notes. So I have a hypothetical patient, young male, early 30s, is coming in for patellofemoral pain syndrome, incredibly active, does resistance training 4 days a week, does 150 minutes of moderate intensity cardiovascular training every single week. He's in very, very good shape. Former D1 gymnast, really takes care of his body. He's got a bit of this inferior patellar pain, this patellofemoral pain syndrome. And this patient works out constantly, is very, very strong, and is sitting in my office asking me for a physical therapy or rehabilitation recommendation. For this patient in particular, because he's so active, I would typically generally ask the patient to recite to me what their mesocycle or training split is. And then I would go in and try to attenuate their load in some way, maybe give them a different form of exercise, maybe decrease the total amount of sets and reps that they're doing, what have you, something to that effect. In the meantime, this patient is looking for some sort of palliative or some sort of temporary disruption for his pain so that he can train with a little bit more ease. In that instance, how likely are you to disagree with the application of manual therapy to that knee?
Great question. And my immediate thoughts are that most manual therapy for patellofemoral pain syndrome have been seen not to be that effective. So I don't think there's going to be much manual therapy that's going to give this temporary modulation of his pain as he's exercising. So I would probably say in that scenario, based on evidence and my own personal experience of doing patella glides and massage around an anterior knee, it often doesn't do much to help make that pain feel significantly much different afterwards.
Mm-hmm.
The only thing that I think probably would do, and I might play around with, would be a bit of offload taping. So I would probably say if that comes under the umbrella of manual therapy, non-active therapy. I would perhaps try some various different ways of taping around the knee to see if that modulated his pain during an exercise or an activity better than I think doing, as I say, patellofemoral glidings or mobilizations or massages there.
Hmm.
So yeah, my sort of view on that would be I would play around with that. But then there's also that question about, is that actually a good idea to do with somebody, that case that you've just presented there? Because with these individuals, if you temporarily modulate their pain, what's probably the first thing they're going to do? Rather than listen to your advice to offload and take things a bit easier, they go, oh, fucking hell, it feels great. The first thing I'm going to do is I'm going to go straight back in the gym and do exactly what I've been told not to do, which is train hard or at the higher level of intensity because it feels better.
Hmm.
So sometimes you're sort of you're creating a bit of cognitive dissonance, I think, for the patients by saying, you need to let this calm down, you need to stop aggravating it, you need to do this and avoid this, and etc., etc. But then you start to say, well, but I can do this to make it feel better, which allows you to carry on doing the thing that I've just told you to stop doing. So I think that gives mixed messages as well in that population. So for that individual, I would say, because he normally falls into this endurance coping strategy with his pain, I don't think, as I say, giving them temporary modulation is necessary or probably the best thing to do either. I think a bit of pain normally allows them to sort of stop pushing it off too much. And if you temporarily change that, they can start to aggravate it more and end up going round in circles.
Hmm. That's a good point. Yeah, that's a very good point. I think a lot of the time, sometimes with my patients who are like they're persistence copers. So kind of like you said, you give them
Yeah,
the transient pain relief, and they go right back to the thing that put them in your office in the first place. But I know
exactly.
that chiropractic students listening to this, I can hear them in my mind's eye. I can hear them right now, and what they're saying is, what if you do the manual therapy and the patient immediately reports, by gosh, after that felt great. My knee feels actually pretty dang good. What do you do at that point? If the patient is
Well,
already almost bought in to the process, do you reject the manual therapy? Do you suggest you try it without the manual therapy?
no, no. Well, the first thing I'd ask is tell me what manual therapy does that, because I'd be very interested to know with anterior knee pain, having tried various different things over the years with it. But no, if there is a good response to pain modulation treatments and somebody gets a significant reduction in their pain and it feels much more comfortable for them to move around and exercise, then yeah, that can be a good thing. That can give somebody this sort of window of pain relief and also this sort of psychological belief that their pain is fixable, it is changeable. And I think that's also sometimes a great win as well. It's a good education tool sometimes to be able to change somebody's pain. And also, it's a good prognosis for a good outcome, because we also see those that are modulatory people. I'm talking about, if people are pain modulatory and their pain can be changed with these things, they often have better outcomes. It means their natural history is probably going to be better than somebody whose pain can't be modulated. You try various things and it always feels the same or worse afterwards. That's telling us they've probably got a much more sensitized neurological system rather than a habituating or modulating neural system. So I think, there are some things there for us to consider when we do change people's pains. It allows us to have that bit more positivity, say, good news, this is going to respond very well with time and various different types of treatments, because your pain is changeable. It's modulatory. Your system is able to change the feelings of what things feel like, which bodes well for the future.
Yeah, I think that's essentially the crux and the double-edged sword when it comes to chiropractic, because chiropractic has almost been changed to be, not changed, but chiropractic now colloquially is synonymous to almost this fast food approach to musculoskeletal pain, where you come in and you expect the chiropractor to in that very instance completely eradicate your pain, and for you to spontaneously recover from a disc bulge the second you leave their office. And that's the double-edged sword that I think a lot of chiropractors have to continuously wrestle with is, yes, I can employ this manual therapy to give the patient some attenuation of their pain, but then it's does this patient become dependent on this manual therapy? Am I making sure that I'm employing active therapy as well? Am I giving this patient a home exercise program? Am I giving them the accurate prognosis of of their symptoms? Am I instilling self-efficacy and faith into them so that they know that the natural history for their condition is good and they're likely to heal over the course of the next 6 to 12 weeks? It's doing all the other stuff that I think if you check off all those other boxes, you can do that makes manual therapy potentially a little bit more open as an intervention choice. I think that the issue is that a lot of practitioners and providers aren't actually doing everything else before the manual therapy lead up. So I think that as long as you do all these other things, manual therapy becomes in a lot of cases, well, maybe, like I suppose you could employ that depending on the patient's preferences and maybe prior experiences that they've had in the past with different manual therapists. Yeah, maybe we can do that. But unless you check off those other boxes, it's like, are you really actually helping the patient? Probably not. You're probably just putting a band-aid by utilizing this temporary pain relief for this patient and their condition. So, yeah.
Yeah. And I think that, sometimes we think that if we use manual therapy and it makes them feel better, that we found a cure for their treatment. And
Mm-hmm.
I don't think that's the case at all. All it just tells us is this person's natural history is probably going to be more favorable. And therefore, I think manual therapy, and I'm not just going to say manual therapy, I'm going to say any type of treatment that neuromodulates somebody's pain often gets the credit of fixing somebody, when actually all it's telling us, this person has a good neurological system, their body is able to adapt, it's flexible, it's modulatory, therefore these people get better natural histories and outcomes.
100%. Yeah, there's often times where I see a patient and we're doing some sort of manual therapy, maybe in the first visit, going over their condition, and then I give them a home exercise program, and they don't see me ever again. The manual therapy acts as this interruption to pain that, kind of like you said, allows them to feel like, oh my gosh, the narrative around my pain isn't that I'm going to be stuck in this painful condition forever. I actually got an interruption, a transient interruption in my pain. So that lets me believe that I can be, or at least have a life that's, a little bit less painful. And then I never see that patient again. And I completely do their care online or give them a rehab program. And it's like, well, the pain stayed away because we were able to give you a little bit of pain relief, and then you just changed you just became a little bit more active. You followed the home exercise program, you did exercise, and you allowed that manual therapy to basically act as like a psychological springboard to make you a more active individual.
Yep, absolutely agree, mate.
Something that I want to bring up with you is one of the formative debates that you had, especially as a chiropractor, that I would refer to often was the lovely debate that you had with Dr. Chad Cook. In that debate, and you did the same thing that I would do if I was talking to Dr. Cook. You lumped manual therapy and dry needling together, essentially stating that they're kind of the same thing. And from a passive modality standpoint, I think technically that's 100% correct. I suppose if Chad wants to nitpick, he could say that they're not precisely the same thing because obviously you're not utilizing your hands, you're utilizing a tool of a needle. But I think for all intents and purposes, it's basically the same thing. Does dry needling confer any unique benefits that would necessitate this distinction?
No, I lump anything where a patient has to lie down and be the recipient of an intervention as a form of manual therapy. So I think, again, I understand that sort of disagreement because the term manual therapy often is synonymous with hands. It's often thought to be, you need to press, rub, pull, massage, click something with somebody else's hands. But I still say anything where a patient is recipient of a intervention where they are lying down on a couch, they're not actively engaged or involved, comes under the umbrella of passive treatments, manual therapy, and that includes, as say, acupuncture, dry needling, electrotherapies. They are all forms of manual therapy. Ultrasound, lasers, pulse shortwave. Anything, as I say, cupping, tool scrape, tool massage, that's using a tool as well, but that's sometimes considered to be manual therapy because it's a massage, whereas something like an acupuncture or a dry needle isn't. And I'm like, what's the difference? There is no difference as far as I can see. So now I class them all under the same umbrella.
Okay, yeah, just making sure I do the same thing. Okay, well, that's good. Um, Going into the manual therapy debate a little bit more, is there ever a case in which you think cervical spine manipulation is warranted?
Short answer, no.
Okay.
I think the very common small transient, short lasting effects are outweighed by the very rare, very uncommon, but hugely detrimental and large potential negative side effects. So I think sometimes with healthcare, and risk reward ratios, I think we forget, or we assume that it's all about frequency. And that's what we're comparing, how frequent are these bad events occurring? But we don't consider how bad these bad events actually are. So I would say that even a million good short-term temporary effects are outweighed by one potential serious, really bad, negative, harmful effect. So again, I know people would disagree with me on that. I'm sure there'll be lots of discussion and debate around that, but my views are, and I know everybody says, well, what about paracetamol? What about non-steroidals? Because that's a question I often get as well, because there are
Mhm.
also risks with these things. But I'm like, yes, there are, but they don't tend to be as frequent. They tend to be more frequent, but not as severe as the risks that go associated with cervical manipulations.
Sure. Yeah, that makes a lot of sense. So I know a lot of students will ask the inevitable question, which I get all the time: if not cervical manipulation, then what? From a manual therapy perspective, in particular, because I think everyone can agree that we give someone 1 to 3 cervical spine exercises, a home exercise program that tends to attenuate pain pretty well for a lot of different people. But if you have someone in your office in a typical chiropractic setting, in particular, again, the patient is looking for some sort of immediate relief. What do you think is the safer alternative in the manual therapy realm to cervical spine manipulation if you had to employ something like that?
So I think simple massage is probably the first port of call that I would go to there. And failing that, I would probably go with a sort of mobilization with movement, a sort of nags or a snags type of thing, as somebody's gently rotating towards their painful side. You're applying some pressure down the vertebral column, and you're just trying to see if you can, again, just create this neuromodulatory effect there. So I'd probably say some of these Mulligan nags and snags might be an appropriate option to consider there. So they're going to be not towards end of ranges. They are done at very low amplitudes and pressures. So there is, as I say, no risk or negative harms that can come from it. It just might not work.
Yeah, I agree with that. There's in my clinical practice, year after year, I find myself utilizing cervical manipulation less and less. And I was already coming out of school, not a huge proponent of it. I'd say right now I perform maybe 2 a week, maybe 3 a week out of all the patients that I see. And that is with patients who have had a robust history of positive effects with cervical spine manipulation and who have gone through our informed consent, which is both verbal and written. And every time they ask for one, I'd go through the same exact informed consent to make sure that they fully understand the risks that they are uptaking with cervical spine manipulation. And I always say, massage, mobilizations, and a whole host of other interventions can provide the same exact benefit, if not better, while completely avoiding the risk for catastrophic adverse events. And a lot of those same patients still say, just give me a crack, please. At that point, I'm a little bit I really am a believer in the ultimate expression of free will, and the informed consent
Yeah.
for me is very, very important. And so for me at that point, if they know what they're getting into, I say okay. But that distinction to say okay is getting harder and harder every single year of clinical practice. And I see myself in the future just completely phasing it out. I see myself in the future just giving them the informed consent and saying, I'm just not doing this anymore. It's just really not worth it. If you're not okay with it, I completely understand. There's a chiropractor down the street. Year after year, I think it gets really hard to justify the potential ramifications of that. And it's difficult too, given my professional title as a chiropractor, that everyone knows us for doing these manipulations, especially the neck manipulation. That's one that people actually come in quite often for. Thankfully, though, and this is surprising, when I came out of school, I thought, when I go through this informed consent with patients, all the patients are going to blow me off and say, I still want the neck manipulation. I find that that is the vast minority. A lot of my patients, after I say, some studies show a 1 in 20,000 risk that you'll suffer a vertebral artery dissection and potentially die from this. A lot of my patients say, then let's not do that. I'm up for whatever else you got, a
Yeah.
lot of them. So I think that right now, coming out of school, chiropractic students learn all these techniques and they know 12 different ways to manipulate the cervical spine. And they feel like they have to utilize that because they spent all this time and this money. But if you do really want to do well by your patient, you care about your patient's health, and you inform them, you would be surprised by how little the patients actually care about receiving a very specific intervention.
Yeah, well, good for you. And I think that's great that you do that and you go through that informed consent process because I don't think that's often done in a lot of healthcare, if I'm being honest. So, yeah, it's refreshing to hear. And I agree that when it is done, a lot of patients, when you do fully inform them of all the benefits, but also all the potential risks, no matter how small they are, it does allow patients to make, I think, better clinical decisions for their own health. And I just think a lot of people are ignorant and unaware of these potential side effects. And it's only until somebody comes along who is ethical and well trained like yourself and explains it to them all clearly that it allows them to actually, for the first time, make a true, good, informed consent about whether they want to proceed or not with that intervention. But there are patients, as you said, that even though you do fully inform and you don't think it's the right thing, will still choose to do things that you will probably not agree with. But as you said, our position as healthcare professionals is not to make the decisions for patients. We are here to present their options and to make sure they are fully informed and aware of the risks. And as you say, it's free will, it's free choice. I often come across this with corticosteroid injections. So I've been trained in my advanced role to use ultrasound guided local anesthetic and corticosteroid injections for various musculoskeletal problems. And I go through the same list of, risks and rewards with these injections. I say if somebody's having it into the subacromial bursa, there's only about a 20% chance it will reduce your pain. So 80% of all these injections don't work. So the number needed to treat is 5 for one person to get a small temporary reduction in their pain. It will be a temporary reduction a lot of the time if it does work. And it comes with some potential risks and harms. If you're a raging diabetic with poorly controlled blood sugars, it's going to cause all sorts of problems with that. It's going to cause hyperglycemia, probably up and down for the next couple of weeks. There's risk of sepsis, there's risk of infections, there's risk of fat atrophy, and there's potential risk of anaphylactic reactions and shock, which are very uncommon, but they can still happen. And that can then cause and lead to serious complications, including death. And you mentioned the D word to patients, and you do see a lot of them, their eyes go up and go, oh, really? But I've had 3 of these already, and my doctor gave them to me. He didn't mention any of these things. I'm like, yeah, I know. I know a lot of healthcare professionals don't. They just say, you need the shot. This will do it for you. And it's only when they get fully informed do they go, well, okay, well, perhaps I'm not going to have the 4th one anymore now then. And I'm like, yeah, good, great idea. But every now and again they'll say, I don't care. Just put the shot in me. I just want the steroid. I'm like, all right, I can only do what I can only do. And then I feel like a bit of a failure and I go and have a shower afterwards with a beer and cry to myself.
Yeah, that's an incredibly similar experience as I have with cervical spine manipulation. Yeah, that sounds about right. Yeah, I had, just to bring up a quick clinical story, I had a patient who she had vasovagal syncope and told me that every time she received a spinal manipulation, she would pass out on the chiropractor's table. And the
Jeez.
chiropractor just went about his manipulation as normal. And then she would get up and say, okay, I'll see you next week. And she came to me and said, hey, do you think we could avoid the cervical spine manipulation? And I asked her why, and she relayed that story to me. And I just couldn't believe it. I practically left out of my chair. And I said, of course, yes, we can avoid what causes you to lose consciousness on the table. Of course. That sounds lovely. I would prefer we did that.
Yeah. Jeez.
Yeah, just crazy. The Wild West out here in clinical practice. Speaking of the Wild West, what are your thoughts? I saw your recent post on blood flow restriction training, so I have a little bit of an idea. But what are your thoughts on blood flow restriction training? So my understanding is that it doesn't necessarily work better than normal loading of tissue, but that it can be used as an adjunct to potentially reduce the load and create a metabolite buildup or a quote unquote pump in patients to stimulate that sensation for them. So, what do you think? Do you think it has any practical application in clinical practice, or you think it's just bunk?
Um, yeah, again, complicated response. Bear
Mhm.
with me. I think blood flow restriction training, as you said, does create this metabolic stress that causes the tissue to respond and adapt. But as you know, and as I know, metabolic stress pales into insignificance to mechanical tension for producing strength gains and hypertrophy effects. Now, obviously, when we do exercise, it's often a combination of all these things stimulating the tissues. But blood flow restriction training is predominantly working on this metabolic stress pathway. It's keeping the metabolic processes in the muscle for longer at lower loads to stimulate a higher load intensity environment. And so, the studies do show that you can get some positive responses from that. But when you compare the responses that you get with BFR compared to somebody that's doing just a slightly bit heavier load without BFR, there's going to be no significant difference. So I think if you can tolerate 40 to 50% of repetition max, I can't really clinically reason or see any evidence to suggest you should be using BFR. If you can't tolerate 40% or 50% of your repetition max because of pain or because of there's a concern to tissue status integrity and it's not advisable to be using those loads, then I could say yes, there could possibly be some clinical utility for using BFR. But it would only until those tissues are able to withstand that 40 to 50% of your one repetition max. So I think soon as you can start tolerating more load, you can start getting into these moderate load zones, then BFR practically has no use whatsoever. So we're only talking these individuals that are only able to tolerate low resistance. These people that are in the 20, 30 repetition rep ranges, where that's all they can tolerate. Then putting a cuff around their limb could create this little bit of adaptive advantage by keeping the metabolites, say, in the tissues a bit better. But, the pain argument I often come across, I think that's a bit of a mute point because anybody who's done BFR properly will tell you that it's not without pain. So again, if it is really just because of pain, I'm going to say, well, if you do BFR, your pain is going to go up compared to what you're probably trying to do with a slightly heavier load. So you need to also know whether the pain is any worse or the same doing BFR as it would do with a slightly heavier load. So if there's no concern about tissue integrity or status, I would suggest trying to do the heavier load without doing BFR to see whether you can tolerate the slightly heavier load, and that way you won't need to use the BFR.
Right. Yeah, that's exactly how I use it in my practice. The first thing that comes to mind is you wrote about postoperative ACLs. I see it a lot with postoperative grade 3 bicep ruptures and reattachment. Um,
Okay.
in
Yep.
in
Yep.
those instances, when the patient is 4 weeks post-op, just moving, trying to get their full range of motion, maybe moving into the 6 week post-op range, I will typically implement BFR and we'll utilize, again, less than 40 to 50% of their one rep max, especially for patients who are fairly strong, and just get, a decent pump in there, a metabolite buildup. And from what I understand, the mechanistic data seems to suggest that potentially BFR lowers the threshold to utilizing upper motor, or excuse me, I'm forgetting the name, high motor unit recruitment. So the metabolite buildup potentially lowers the threshold to utilize high motor unit recruitment,
Okay.
which is what we need to maximally utilize mechanical tension for the hypertrophy stimulus. Anyways, it seems to make it difficult or more difficult for the patients to utilize lower loads, and that perceived effort I feel like can be useful for patients who have that tissue deformity or injury or what have you. But then there comes to a point, I think the question really with BFR is at what point is it beneficial to switch using BFR and go towards more normal loads? Because that's what I find is relevant in my clinical practice. It's the distinction between, okay, can you actually do heavier loads now? Let's give it a whirl. Let's take the cuffs off. Let's see what you can do. Is it too painful? Okay, let's go back down. Let's put the cuffs back on. Let's use those lower loads to really utilize BFR to its maximum potential. So that's where I find like BFR might be useful. But for able-bodied patients who don't have an affected limb, I really don't find that it's useful at all. But for patients who do have an affected limb, sometimes I try it.
Yeah, no, and it's a great point. When is the time to stop using BFR and go on to slightly heavier loads, and particularly with a limb that's got some tissue that needed to be protected post-surgical. That is it's a grey area. There is a lot of individual variation based on the patient's tissue status, their health, their comorbidities, their age. All these things are going to affect how tissue responds and heals. So it isn't going to be a black or white line in the sand that says, at 6 weeks post surgery, they can definitely start taking 50% RM. There's going to be this sort of transition phase that there's a lot of uncertainty. So, yeah, I agree. I think, in tissues that need to be protected, post surgery is the main one. After a tendon repair, absolutely. I think BFR in those early stages has some utility. It's just that question about when and how long for is a bit uncertain. I would say probably no more than probably a couple of weeks, 6 weeks for most, I'd say post surgery, and then they should be able to be off BFR. And I always say to a patient, if you're going to use it, you want to try and make sure that you can get off it as soon as possible. You want to try and make sure that safely you can get your tissues to start to respond to the higher mechanical loads rather than just loading them with these lower loads with this BFR on, because it's not going to actually stimulate the tissues the same way. It's the mechanical tension that's needed for a tendon to return and restore its resilience and robustness.
Right. Yeah, 100% agree. Oftentimes I use the BFR cuffs as almost like I use the higher load and the BFR cups in tandem with one another, almost like a barometer to say, can we utilize higher loads? Is it too painful? Let's go back down. But yeah, I think really I haven't ever trained anyone or done rehab with anyone past that 6 week mark with BFR. A lot of the times I use it in a short stint of like 2 to 3 weeks. And then I find that for whatever reason, the patient can actually use quite a bit more load after that.
Yeah, and I think there's probably a number of reasons for that. One of them, I think, is it because it just, again, for some individuals, it sort of recalibrates their pain tolerance thresholds massively.
Yeah, that's a good point. So we're coming up to the final few minutes of our hour, and the last question that I have is a little bit more of a philosophical one. If you could go back in time, would you still choose to be a physio?
Yes, no. um, Well, that's hard to say. I mean, currently where I am at the moment in my career, I'm very glad that I'm a physiotherapist. I've done well for myself. I've managed to achieve a lot, and probably a bit more than I anticipated I ever would do as a physiotherapist. So, I've been fortunate and very grateful for that. And I am in a very favorable position and an enviable position, I think, as a physiotherapist with my reputation and my profile and my working life and my career. So yes, if you were to say now, I would say, yeah, I definitely would. And I am glad I went down the physiotherapy route. But if you were to talk to me probably 10 years ago, maybe even a bit less than that, maybe 7 or 8 years ago, I'd have probably said, no, I'd have had some regrets. I'd have had some doubts whether this was the right career path and whether I should have stuck with personal training and coaching and strength and conditioning, or even, stuck in the military. Because, I've got some friends and colleagues in these industries and these professions that have also done very well for themselves. And when I look back, when I was, say, 10 years ago compared to where they are, I was feeling a bit envious. I was thinking, look where these guys are compared to where I am now. But I've slowly caught up. So now, as it seems to be, as a position where I'm quite happy to be a physio, and I do recommend it to a lot of people who consider this job. I just say to them, it's not a smooth journey, but then any career and any professional will probably tell you the same thing. There's good, bad, and in between days and months and years, and it's about riding the rough with the smooth. But in whole, it's a good career. It really is. I don't know of any career that can give you such a mixture of emotions from one day to the other, and again, just make you feel positive and happy that you're helping and supporting and coaching people in this world where, it's unfortunately, because of modern life, it's becoming harder for people to remain active and healthy and fit and well. And we're just here trying to feel that and help that out a little bit more, one person at a time.
That's good. Yeah. That I had I think that for me and for a lot of the people that I speak to who are professionals in the same sector as we are, I think the closer you are, and maybe this wasn't the same for you, but the closer you are, I feel like to graduation, if you're not disillusioned by all the stuff in the profession, as soon as you graduate, there is an immediate wave of maybe I made the wrong decision. And then as you continue to treat patients, it's almost like the goal and the reason why you got into the healthcare sector in the first place becomes even more clear. It's like all the other BS kind of goes away and you realize that you're really in this to help people. And I think it's the years of experience that temper your own cynicism, I think. And I find that with myself too. Immediately after walking across the stage when I graduated, I'm like, I should have been a DO. And then I get into practice and I'm like, oh, this is actually pretty cool. This guy came in with, rotator cuff related shoulder pain, and now it's much better. He can pick up his kids, he can throw a ball, he can lift weights. This is great. And then it just comes in waves. I should have been a DO. And then it clears up again. And
Yeah.
that stint in time where I regret my choice becomes shorter and shorter as the years go by. And I hope, by the 20-year mark or 30-year mark, I won't have so many moments in the shower where I'm regretting my decisions in life.
Yeah, no, I agree. It definitely is a roller coaster with good and bad. And as I say, it does as time goes on, the goods start to become more and the bads become less, definitely.
Yeah, awesome. Well, thanks so much for your time, Adam. It's been an hour, and it's been an honor to have you as my second guest. I've watched you for a very long time. I think a lot of students have also watched you for a very long time, be that physios or chiros, and we'll get a lot from this discussion, especially when it comes to the manual therapy debate and some of those questions that we went a little bit deeper into. I think that it's hard to get a concrete picture of things like people like you and I have to say on Instagram because we have limitations from the limitations in our slides to the limitations in the character text box below for our summaries. So once you actually get into a little bit more long form content, it's easier to flesh out these ideas and get a better idea of how we practice and what we actually truly believe in.
Yeah, thank you for the invite and appreciate the discussions. And it is good to be able to say, put that little bit more nuance and grey into things rather than it sometimes appears on social media. And say it's not always black and white. And sometimes, social media puts things into tribes where you're either for or against a lot of the time. And I think, as I say, a lot of the time it isn't either or, it's often both. It's a little bit of this, it's a little bit of that. And to say it's a good to be able to get that explanations and points across, to say with that little bit more nuance. So I appreciate it.
Fantastic. Well, thanks everyone for listening. This is the Rehab Chiro podcast, and this was Adam Meakins. Take care, everyone.